Is there anything that we can do to reverse atherosclerosis, particularly of the coronary arteries?
Yeah, so reversal of atherosclerosis is a fairly controversial topic, I'll say. And a lot of it comes down to how are you measuring the atherosclerosis. So we can look at something like a coronary artery calcium scan, which I think is the best screening test for atherosclerotic heart disease. And whether or not you can actually reverse coronary calcium, whether you can lower coronary artery calcium scores, is controversial, but I've seen it happen in practice. So it is possible. And then when you go beyond that, and if you look at something like a coronary CT angiogram, which is going to show you both soft plaque and calcified plaque, you have more capacity, it seems, to reverse the non-calcified soft plaque than you do the calcified plaque. So I do think reversal of heart disease is possible. Just conceptually, I think that the body can heal itself. So why wouldn't it be able to heal this damage when it can heal all other sorts of damage?
Today's show with Dr. Phil Ovadia, who's, by the way, a cardiovascular surgeon, and this is a phenomenal discussion, probably one of the most comprehensive conversations we've ever had on all things cardiovascular and metabolic health. I really, really hope you enjoy this episode, brought to you by Myoscience Nutrition, because we're talking so much about the importance of metabolic health. You need to know about berberine hydrochloride. This is a natural product that has been used in traditional Chinese medicine for the better part of 3,000 years. What I love about berberine is it's a natural appetite suppressant, and many of us derail our metabolic health quest and journey by consuming some junk food, cookies, crackers, treats, and ice cream, or even alcohol in the evening time. And so berberine can be used to help curb those pesky evening food cravings, in addition to supporting fasting physiology, increasing ketones, and helping to support overall metabolic health. So you can save on this unique formulation known as the Berberine Fasting Accelerator over at myoscience.com. That URL again is MYOXCIENC.com, myoscience with an X, and be sure to use the code podcast at checkout. So before we cut back to it with Dr. Phil Ovadia, I just want to say this is a phenomenal episode. I really hope you enjoy it. I think you'll find the show notes very helpful in this conversation. We talk about cholesterol, we talk about natural ways to reduce blood pressure, how to optimize hormones. We talk about potential problems with seed oils. We talk about so much more. Definitely check out Dr. Phil's book that I will link in the description below. And without further ado, let's cut back to it and talk about all things cardiovascular disease prevention.
Well, Dr. Phil, it's great to be with you. I know we've had conversations over the years about doing this together, and here we are at Metabolic Health Summit in Tampa, Florida. So cardiology and cardiovascular disease, unfortunately, as you know, the stats, 630,000 people every year are dying from this very preventable disease. And as a cardiac surgeon, you've seen many people on the operating table who probably shouldn't be there had they not made a lifelong series of poor lifestyle choices. So how preventable is cardiovascular disease, particularly in people who have a first-degree relative who might have high blood pressure, or, for example, in my case, my grandfather died of congestive heart failure at 74. Didn't exercise, ate a lot of processed food, things like that. So how preventable is this if we are at higher risk?
Yeah, that's a great question. And I think ultimately most heart disease is preventable. And I would say, some of the statistics would suggest up to 90% of heart disease is preventable. We've gotten this concept that genetics are more important than they actually are. And I think what we've lost sight of is within families, it's not just genetics that get passed down, it's habits. And these habits we know have a massive influence on our health. We have the statistics. 88% of the adults in the United States are in not optimal metabolic health. When you go back, it's interesting in the cardiac literature, when you go to sort of the era before we were so focused on cholesterol, there was a lot of interest in insulin resistance and its relationship to cardiac disease. Gerald Reaven, among others, did a lot of this work. And his studies suggest that up to 95% of patients with cardiac disease are insulin resistant. And we know that insulin resistance is largely reversible. So that tells me that a very large percentage of cardiac cases are preventable. And quite honestly, today, I consider that every patient that ends up on my operating table is a failure of the medical system. I'm not blaming the patient. The patient's gotten bad advice, bad information, and a lot of times the patients are following the advice that they've been given by their physicians, but they're getting bad advice from their physicians. So I view it as a failure of the healthcare system almost each and every time a patient ends up on my operating table.
Which is really unfortunate. And part of that bad advice is adhering to a low-fat diet. We've been told over and over again for the past 60 years that fat is the problem, and it so-called clogs the arteries of the coronary vessels and so forth. And why is that, in your opinion, now, if we know that majority of cardiovascular disease has some element of insulin resistance, how is the low-fat diet advice exacerbating this underlying problem for people?
Yeah, the problem with the low-fat dietary advice is it pushed people towards a higher carbohydrate diet and a more processed diet. And we now know, I think the evidence is abundant, that processed food and high carbohydrates are the two primary drivers of metabolic disease. And metabolic disease and insulin resistance is the primary driver of heart disease. So this focus on fat, which again has been thoroughly disproven, dietary saturated fat as a driver of heart disease has been thoroughly disproven in the medical literature, and even the American Heart Association and the dietary guidelines have removed the limits, the suggested limits on saturated fat from the diet. Yet it's still a commonly held belief among practitioners and the general public that saturated fat in the diet is bad and low-fat diets are beneficial. What I look at is, we've run this experiment to its completion. As you said, 60 years we've been giving the same advice, low-fat diet, and it's failed miserably. Heart disease remains the #1 killer. We really haven't had a meaningful impact on the incidence of heart disease. We've gotten better at keeping people with heart disease alive longer because we have things like stents and bypass surgery that we can do more successfully. But most of those people still end up dying of heart disease. They just die later of heart disease.
And they're sicker in the process, and quality of life is not as good and all of that.
Exactly.
So what is it about the heart and insulin resistance specifically that exacerbate the functional decline of the cardiac muscle? And maybe we can speak to the coronary arteries and atherosclerosis. I think this is really confusing for a lot of people because you hear about this narrowing of the arteries, and part of that is calcium and cholesterol deposition and so forth. So how is it that human physiology, we haven't sort of figured out a way to better innervate the heart muscle, so to speak, and why are these arteries so susceptible to becoming occluded or narrowing or clogged, if you will?
Yeah, so it's interesting when you look at the impact of insulin resistance on the blood vessels in general throughout the body. Again, we can demonstrate that they damage the blood vessels. Why are the blood vessels in the heart more susceptible than perhaps blood vessels elsewhere? I think first it probably just has to do with a size issue. The blood vessels on our heart are some of the smallest arteries in our body, and they're serving a very important function. So when a blood vessel in your leg, especially a small blood vessel in your leg, might get blocked up, you may not notice much effect from that. But on the heart, that blood supply is so vital, and so I think that gets magnified when the blood vessels on the heart get damaged and get blocked up, and that's why atherosclerotic heart disease is such a impactful disease. Blood vessel disease, atherosclerosis elsewhere, you can live with. It's going to impact quality, but it doesn't tend to be life-threatening in the same way that atherosclerotic heart disease is.
And for reference point for people, if they're envisioning like a shoelace or a pen, how big or small are the coronary arteries? What's a reference? That we can...
Yeah, so we're really talking, a couple of millimeters. So you're talking like a spaghetti strand, is the coronary arteries, the blood vessels on the surface of the heart that are then supplying the muscle of the heart with oxygen.
And it's usually those vessels that become occluded or clogged where you have to come in as a surgeon to then, or the cardiologist will stent them, or you do bypass. Is that really part of the pathophysiology?
Correct, yeah. So atherosclerotic heart disease is the most common form of heart disease. It's not the only one, but it's the most common one. And when most people are referring to heart disease, that's what they're referring to. And, at its essence, atherosclerotic heart disease is a buildup of plaque in these arteries that will either slowly over time or sometimes quickly, acutely, decrease the blood flow to the muscle of the heart and therefore decrease the oxygen supply to the muscle of the heart. And then when you're not getting enough oxygen to the muscle, like any other muscle, that is then going to start to damage the muscle.
And we would characterize that as an infarct? Myocardial
Yeah, so it can either be, if it happens suddenly and you completely cut off the blood supply, that's going to be a heart attack, a myocardial infarction. Okay. If it happens slowly and you're kind of gradually reducing, you can get what we call ischemia, which people will know as angina, chest pains, that aren't a complete loss of blood flow, so you don't get, dying of the muscle, but the muscle can't meet its metabolic demands. And obviously, there are very high metabolic demands with the heart constantly beating, so that becomes a problem as well.
Interesting. And so is it the ischemia that triggers the reduced cardiac output? We hear about left ventricular hypertrophy in that and poor output and cardiac ejection fraction. Is it that the heart muscle is just not able to do its job? Is that leads to the atrophy?
That can be one of the consequences. So you can start to get, what we call left ventricular dysfunction. Reduced ejection fraction is another term that people will hear about. But the actual function of the heart starts to diminish because, again, it's that muscle isn't being supplied with enough oxygen and blood and energy to do what it's being called upon to do.
Fascinating stuff. So to summarize, the metabolic milieu from insulin resistance is just causing vascular dysfunction throughout the body, but we're seeing the manifestation of that more prominently in the heart because the vessels are very small and the heart is very metabolically active. What comes to my mind is the importance of exercise. If we think about exercise, all of your muscles are getting blood flow, including your heart. So it seems like in addition to cutting out the processed foods and seed oils and sugars and things like that, exercise is wonderful for the heart and possibly keeping these arteries from becoming occluded or narrowed.
Yeah, so, exercise has never really been shown to help prevent atherosclerosis, but that doesn't mean that it's not beneficial. And, the way to think about it is the stronger your heart is to start with, the more it's going to be able to tolerate, the decreased blood flow. So as you're having decreased blood flow, you're going to have more capacity to deal with that, I guess is how I would put it. And it's like any other muscle, the bigger it starts, if it then starts to atrophy or weaken, you're going to be able to tolerate that from a symptomatic standpoint. But it doesn't really change the damage that's being done. So exercise is certainly helpful, and we know that things like building muscle can help protect your metabolic health, can help protect you from insulin resistance. So in that sense, it kind of indirectly is helpful in preventing atherosclerosis.
Interesting. There was a recent study, I'm sure you came across it. Individuals who had angina went to, I think it was just a hospital type setting. They followed these people over years, and they looked at their isometric leg strength, and they found that people who had lower leg strength upon admission to the hospital for angina lower leg strength lived much shorter, died from a future cardiovascular event compared to people who were stronger. And in my opinion, that was probably related to their activity levels of daily living, exercise, and all that. But if you have a weak muscle in the heart, it makes sense that if you do have this narrowing, that it's just going to be more vulnerable to future challenges.
Yeah, exactly. And grip strength in a similar fashion has been shown to be one of the best predictors of not only lifespan, but health span, functional health span. And the bottom line is the better you're able to maintain muscle as you age, the better you're going to deal with the aging process.
Love that. I want to get into blood viscosity and more exercise and diet specific things, but you mentioned exercise does not reverse atherosclerosis. There's been some talk about proteolytic enzymes and fasting and autophagy and dasatinib and rapamycin and all these different things. What comes to mind, or is there anything that we can do to reverse atherosclerosis, particularly of the coronary arteries?
Yeah, so reversal of atherosclerosis is a fairly controversial topic, I'll say. And a lot of it comes down to how are you measuring the atherosclerosis. So we can look at something like a coronary artery calcium scan, which I think is the best screening test for atherosclerotic heart disease. And whether or not you can actually reverse coronary calcium, whether you can lower coronary artery calcium scores, is controversial, but I've seen it happen in practice.
Cool.
So it is possible. And then when you go beyond that, and if you look at something like a coronary CT angiogram, which is going to show you both soft plaque and calcified plaque, you have more capacity, it seems, to reverse the non-calcified soft plaque than you do the calcified plaque. So I do think reversal of heart disease is possible. Just conceptually, I think that the body can heal itself. So why wouldn't it be able to heal this damage when it can heal all other sorts of damage? Now, what I think is important for people to understand is the data that we have on coronary artery calcium scoring shows us that as long as you stop the progression of coronary artery calcium, as long as it's not getting worse over time, that means that you're at a lower risk for a clinical event. So, for people who maybe got their first coronary artery calcium score and it's elevated and, they're thinking this is sort of a death sentence, I try and give those people hope. I want to empower them to understand that you don't even actually have to reverse the disease, you just have to stop it from getting worse over time.
That's really important. Like if you formerly smoked or vaped, just stop now and you may not reverse that calcified plaque, for example, but it's not going to progress.
Exactly. And same thing from a dietary standpoint. If you've had a poor diet, ate a lot of processed food, and you've developed this coronary calcium, changing those habits can stop it from getting worse. And again, sometimes we see reversal, sometimes we don't, but as long as we stop it from getting worse, that gives you a very good prognosis.
I love that. I think that's really empowering for people. At what age should folks consider start doing this? And is the CCTA, is the acronym for this coronary calcium angiogram?
So CAC, coronary artery calcium scan, and then CCTA, coronary CT angiogram. So two separate tests, very important for people to understand as well. The coronary artery calcium scan is kind of the screening test. It's an easy test to do. Takes literally about 5 minutes in a CAT scanner, no IV, no dye, very low radiation exposure. So it's a test that I encourage people to get early and then to repeat over time to follow this progression. The coronary CT angiogram is a more detailed test. You do have to put an IV in you. It's a higher radiation exposure. So it's a test that probably can't be done as often on people. And so I kind of use that as the second level test. If we have reason to be especially concerned, maybe you have a very high CAC score or you're having symptoms of heart disease, the CT angiogram becomes a better, a great test. From a practical standpoint, people are always thinking or hearing about, how blocked are my arteries? Are they 50% blocked? Are they 70% blocked? The CAC scan doesn't give you that information. The CT angiogram does give you that information. So again, I usually tell people start with the CAC scan. I think for men, probably in your 40s is a good place to start. Women tend to be about a decade behind men in terms of their development of heart disease. So 50s is probably okay. Now, if you have a strong family history, if you know you're metabolically unhealthy, you're insulin resistant, you're overweight, obese, you might want to start earlier. The reality that I see today as a heart surgeon is younger and younger patients are ending up on my operating table. It's really not that uncommon anymore that I have 30 and 40-year-olds on my operating table, which tells you that they probably started forming plaque in their 20s. And so, you know, there's probably a lot of people that need to be screened even earlier.
Right, with a CAC. And would that be an annual thing? I mean, let's say, again, someone's been eating fast food, smoking, poor sleep, works the night shift, whatever. Is this an annual thing or every 18 months, or how frequently would you recommend follow-up testing?
Yeah, so it's going to depend on your situation, you know, and, you know, if you get that first one and you have a 0 score, which is what we all want, you probably can wait a number of years. The older you are with a 0 score, the more meaningful it is. So if you're 60 and you have a 0 score, that tells us that over the next 10 years, you have about a 1% chance of having a heart attack. Wow. Very low. So, you know, if you're in your 60s, you get a 0 score, you could probably wait 5 to 10 years. Now, if you're in your 30s and you get a 0 score, not as meaningful. And, you know, those people I usually say, we should probably recheck in like 2 or 3 years. And if you have a non-0 score, now I want to track that over time. And those are the patients that I'm oftentimes getting annual scans on to see their progression over time. Because again, we know that if you don't progress or you progress very slowly, that's going to be a better situation than if you're progressing quickly.
Okay. So let's say, how often do you see this clinically? Because I'm sure patients seek you out because you're getting your work out there with your book and podcasts, which is fantastic. An individual have a 0 calcium score, but say a high LDL cholesterol or high apolipoprotein B. How common would that be now that so many people are doing low carb or 0 carb?
Yeah, so I do have a very specialty practice, and I attract a lot of these people because this is the very controversial situation. And at this meeting, you know, 2 great presentations by Dave Feldman, Nick Norwitz on this topic. So my practice is admittedly biased, but I see it a lot now because the patients find me. And they have a high LDL, and they've been told by their doctor that's a dangerous situation, but they're metabolically healthy, they're not insulin resistant, they have low inflammation markers, and they have a 0 CAC score. And ultimately, I think that conversation has to come around to the amount of your LDL isn't the whole story. The quality of your LDL cholesterol particles is very important in this. And so that's where we get into advanced lipid testing, looking at particle sizes, perhaps looking at oxidized LDL versus, you know, non-oxidized LDL. That becomes part of the conversation. But ultimately, I think we're accumulating more and more data that shows us that all high LDL isn't the same. And yes, sometimes high LDL is a problem, but sometimes it isn't.
Right. Well, this is a very nuanced perspective, and I think it's going to take mainstream medical doctors a long time to grapple their head around this, because I used to actually sell a test that was a competition for the Berkeley Heart Lab analysis that came out, I think, in 2006. You know, the LDL subfraction testing has been around for a long time, and still, I often see people that I work with on a nutritional perspective, their LDL is high, we have no ApoB, no subfraction. How many more decades do you think it's going to be before this nuanced perspective is going to make its way into clinical practice?
Yeah, I think it's still going to take quite a while because, quite frankly, doctors aren't educated about this. You know, prior to my self-education process around low carb and ketogenic diets and stuff, quite frankly, I was never taught about LDL subfractions and understanding the advanced lipid panel. So I think very few practitioners are, you know, well versed and knowledgeable in this. And, you know, the healthcare system wants broad guidelines that are easily applied. And the reality of the situation is that for most people with elevated LDL cholesterol, that's going to be combined with metabolic disease. As I said earlier, 90% of adults essentially are metabolically unhealthy. So for most of the people with high LDL, they have that very dangerous combination of metabolic disease and high LDL. But I think it's incumbent on us as practitioners to also figure out who doesn't fit in that situation. Who are these people that have a high LDL, but they are metabolically healthy, they're not insulin resistant, their particles look good, and so those people, there's really no reason, there's no data that we have that shows that lowering their LDL is of any benefit, and there may actually be some harm associated with that in some of the studies we look at.
I love that. I'm glad you hit on the fact that there are a large subset of the population that have high LDL, in addition to high triglycerides, low HDL, insulin resistance. In those situations, do you recommend statins, or do you focus more on the insulin resistance and weight loss? What is the best clinical track? Because that's, as you mentioned, very common.
Yeah, and that's exactly the conversation I have with patients in that situation. Yes, you can take medications to lower your LDL. There is going to be a small benefit, and understand that that benefit is a lot smaller than it's purported to be. And you're exposing yourself to the risk of, taking these medications or doing the dietary interventions. You can say, okay, low-fat diet, it's going to lower my LDL, but at what cost?
Right.
And
can I interrupt you there?
Yep.
And the cost, meaning hormone issues, brain issues, memory decline, diabetes. What's the consequence of lowering your LDL with, say, statins?
So with statins, again, the medications, yes, exactly. We know over the long term, for instance, that statin use more than 10 years increases your risk of developing insulin resistance and type 2 diabetes, which are two primary drivers of heart disease. Wow. So this is why I think the statin data is so disappointing when you really look at it objectively. Again, the absolute risk reductions in heart disease for people taking statins over long periods of time are minuscule. They're like 1%, 2%. 4% in the best studies, secondary prevention, people who've already had a heart attack. But of course, as you're well familiar with, and a lot of your audience is well familiar with, we manipulate the way that this data is conveyed to the public and to practitioners. We use relative risk reduction instead of absolute risk reduction, and it makes it look like there's a greater effect than there actually is. So that's the conversation I have with patients. I said, yes, you can take these medications, you can expose yourself to the risk of the medications, or you can change the way you eat, you can deal with the true underlying problem, insulin resistance, and that does cause a much greater magnitude reduction. If you fix your insulin resistance, and again, you shift those lipid particles to the large, fluffy, healthy LDL particles, now again, you're in that situation where the medications aren't going to be any benefit, so you don't have to worry about them. And most people, when they're given the option in that way, they're like, sign me up, tell me what to eat. I don't want to take a medication for the rest of my life.
Yeah, especially if, as you mentioned, the absolute risk reduction is single-digit percentage, so we're talking about very, very small. Do you think some of the benefits of statins are the indirect so-called pleiotropic effects of anti-inflammatory in this? And there's a million other ways to reduce inflammation.
Yeah.
But is that part of it?
Yeah, definitely so. Inflammation is a very important part of the development of heart disease. So statins do have an anti-inflammatory effect, but as you said, there are much better ways to lower inflammation without taking on the risk of statins.
Sure. Along the lines of statins, and not to pivot too much away, I want to continue this trajectory a little bit, but I was really surprised when I started work with a medical doctor in Colorado, seeing patients on a nutritional perspective in his office, Gerard Guillory, and many of these patients had high lipids and high blood pressure, and they were given beta blockers and thiazide diuretics, which, as you know, also have the same consequence as the statins do in exacerbating insulin resistance. And I thought that was just so perplexing to me that the very conditions that are being used probably to mask the symptoms that are manifesting from their insulin resistance, i.e. high blood pressure, were causing more insulin resistance. So can you speak to the people right now, because there's many people still prescribed thiazide diuretics and beta blockers, maybe having a conversation about looking at something like an ARB or a calcium channel blocker or ACE inhibitor?
Yeah, and really two parts of that conversation, because again, high blood pressure is a huge missed opportunity. The vast majority of hypertension, high blood pressure, the root cause is insulin resistance, metabolic disease. Again, so instead of just, using the medication, putting a Band-Aid on the symptom, let's look at that root cause. Right. So again, patients that come to me with high blood pressure, oftentimes we're able to get them off their medication when we get them when we fix their insulin resistance. When we get them metabolically healthy, their blood pressure improves, and you can usually reduce or eliminate the medication. But I would agree that, there may be better medication options, other alternatives like ACE inhibitors or ARBs, ACE receptor blockade, that might have advantages over beta blockers, over diuretics. And again, most doctors, they're not trained to think this deeply about it. They have the guidelines, and they're kind of checking boxes off on the guidelines, and they're really, quite frankly, not knowledgeable enough, and they don't have the time to think about all these things, and that's where the systemic issues come into play again.
Yeah, I'm glad you mentioned that, because many of these doctors are really well intended, but to get paid or reimbursed, especially if they take Medicare, they're spending hours and hours documenting, and they're just so backed up. I mean, it's just incredible, the documentation and things like that, which is really, really challenging. So the oxidation of LDL cholesterol, do you like to look at the ox-LDL panels? I know Cleveland Heart and some others are coming up with this. Let's just say someone's a little scared. They're low carb, their HDL is low, the HDL is high, triglycerides are low, but LDL is a little high. Yeah. They're concerned about this. Do you look at LDL oxidation? Is that something that's clinically useful, or do you?
Yeah, so I don't, I'm not a big fan of the ox-LDL test, and the reason is that it tracks with your LDL. The more LDL you have, the more oxidized LDL you're going to have. So we run into the same situation where, a patient will get tested for that. Their LDL is very high. Their ox-LDL by the lab normals is high, but as a percentage, it's actually low when they have when they're not insulin resistant. So I don't find ox-LDL ends up adding much above and beyond if you're looking at their particle sizes. Now there is one lab company that has a sort of indexed oxidized phospholipid test, where it's oxidized phospholipids divided by ApoB. So it sort of controls for that a little bit. That may be a better indicator. But ultimately, when you, if you combine a advanced lipid panel, an NMR panel that's going to show you your particle sizes, you do an insulin level and some assessment of insulin resistance, and that can be something like a HOMA-IR calculation. That can be the lipoprotein insulin resistance score, LPIR, which I am a very big fan of. And you check some inflammation markers, something like CRP. That gives me enough information that I really don't necessarily have to go to the ox LDL test.
I like that, because everything that you just mentioned are available from LabCorp Quest. You don't have to go to a boutique lab and spend $300, which is really fantastic. What about iron? We hear a lot about iron overload, and people have thick markers of increased blood viscosity. Hemoglobin, hematocrit are elevated and all that. What weight do you consider that a risk factor? And then do you ever recommend blood donation for folks?
Yeah, so, and this really looks at, gets into ferritin levels. And ferritin's a very interesting marker, because ferritin actually is measuring two things at once. It's measuring your total body iron stores, but it's also an inflammation marker. It's what we call an acute phase reactant, and it will go up with inflammation. So when someone has an elevated ferritin level, you need to dig into, is their ferritin elevated because they have elevated total body iron, or do they have inflammation, or do they have both? And again, that's going to lead you sort of down different pathways. Ultimately, blood donation does reduce ferritin. We know that increased ferritin is a risk factor for cardiovascular disease. So if I have someone who has high ferritin levels, and we're pretty convinced that they don't have inflammation or they've addressed their inflammation, blood donation can be a useful tool in that situation. But again, it's not, I don't want to fall into the trap of just saying high ferritin, go donate blood. I want to figure out why is that ferritin high.
Yeah, what's driving it.
Yeah.
Yeah, that's really important. I remember I took my labs. I've been doing Chem 24 and CBCs and just your standard blood work. A mentor taught me this in 2006. I happened to get some blood work after I got a cold, and my ferritin, it looked as though I had hemochromatosis. And of course, the young, naive, overexuberant health seeker in me was like, okay, I got to get this gene test and this. And my mentor said, you're probably sick, just rerun the test. I was like, okay. And reran the test, and sure enough, it was back down to like 110 or whatever it was. But it was like 500.
Yeah.
So it was really interesting to me to see the acute phase reactant of ferritin being involved in immunologic responses after just like a seasonal cold.
Yeah.
Which was...
And that's, I think, another good concept for people to keep in mind with lab testing in general.
Yeah.
It's trends. It's not
a one-off.
Necessarily a one-off, a one-time value. I see the same thing with CRP testing, C-reactive protein, another inflammation marker, and people will come and their CRP is through the roof, and then I'll be like, well, were you just sick? Did you get your blood work drawn after doing a very strenuous workout or, an endurance event? I personally had the experience many years ago of, my CRP usually runs pretty low, and all of a sudden it was high, and, again, I'm going through that similar thing, and then I'm like, oh, I got badly sunburned, 3 days before.
Wow.
With all of these markers, you need to keep in mind context, and you need to look at it overall, and that's why I think narrowly focusing on just one marker is never a good idea.
Yeah.
There is not one blood test that tells us everything that's going on in your body.
Right.
And that's one of the other criticisms I have about this sort of LDL-centric model. We take people that are doing, for instance, low-carb ketogenic diets, and we see all of these markers that move in what are considered a positive direction. Their hemoglobin A1C goes down, their inflammation markers go down, their insulin level goes down. And yet, we get hyper-focused if one metric goes in what we consider to be the wrong direction. Their LDL cholesterol goes up, and everyone freaks out and says, basically, I don't care that you've lost weight, you're feeling better, and all of your other markers look good, because this one marker moved in this direction, this diet must be killing you, and you have to stop doing what you're doing.
It's wild. It's just that dichotomous thinking, we fall into these binary traps. This is one thing is good or one thing is bad. Meat is bad, all plants are good, right? These conversations. So yeah, it's really important that we understand that. A little bit esoteric research suggests potentially that consuming linoleic acid in the form of canola oil, safflower oil, maybe cottonseed oil, may be increasing the susceptibility of LDL to become oxidized. The so-called linoleic acid LDL oxidation hypothesis. What are your thoughts on that?
Yeah, I think there's certainly some validity to that. We have sort of the mechanistic studies that show this. These polyunsaturated fatty acids are more susceptible to oxidation, and that's going to be going on in our bodies. Now, what becomes tough to separate out is kind of the question of what's the most dangerous part of processed food, right? We know processed food is bad, and then everyone wants to know, well, is it, all the fake, processed oils? Is it the processed carbohydrates? Is it the combination of it? And in the end, I kind of zoom out and say, I don't know, but I know that not eating processed food is good for you, so eliminate the processed food, and that's going to kind of eliminate all of this stuff at once, Again, short of, I guess, drinking vegetable oil, you're not going to get exposed to these vegetable and seed oils in high quantities if you're not eating processed food. And so that's why, I try and keep the advice simple for people, and my message is just eat whole, real food first and foremost.
I love that. And it seems that the research is a little bit biased towards a plant-based diet when it comes to preventing cardiovascular disease in this. What would be your thoughts on that?
Yeah, so I think plant-based diets have been shown to be better than standard American diets. And again, that's largely because some plant-based diets eliminate processed food. Now, you can do a highly processed plant-based diet, and I don't think that's going to be any better for you. Yeah. But I think any diet that eliminates processed food is going to improve, your outcomes. What's never been done is a plant-based, non-processed plant-based diet versus a carnivore diet, for instance. That comparison has never been done. Yeah. And then, what happens in this sort of plant-based focused world is they say, okay, we've eliminated processed food, our health got better, and it has to be the meat that's part of that processed food, right? They don't separate out the fact that, when someone goes to McDonald's and gets a hamburger, yes, there's meat there, but there's the bun and the fries and the soda and the toppings. And, that is never really separated out well in these studies that show benefits of plant-based diets.
Really important point, and especially considering the fact that Chris Gardner et al. Over at Stanford recently published that study randomizing twins to either eat a healthy omnivorous diet versus healthy plant-based diet. And we just spent the last 10 minutes talking about how myopically focusing on LDL cholesterol is missing the boat. But curious enough, even though that was published in the New England Journal of Medicine, that paper myopically focused on LDL cholesterol. What would be your thoughts on that? Why aren't we looking at body fat percentage changes, waist circumference changes, triglyceride elevations in the plant-based diet group versus omnivorous group? Any comments on that?
Yeah, I think the reason they don't look at it is because they don't want to know what that data is going to show. LDL is serves that dual purpose of, yes, eating a plant-based diet versus a, omnivorous diet is going to lower your LDL cholesterol. Yeah. And, the assumption that we've now accepted in the mainstream is that that's going to lead to better health outcomes. Right. And I would argue that we really don't, that contention isn't supported in the literature, but it's used as another vehicle to promote plant-based diets. And we know that there are many non-health related reasons that plant-based diets are getting pushed. And so it just fits into the overall narrative, and I think that's what continues this myopic focus on LDL cholesterol.
Yeah. What about the omega-3 index? So Bill Harris has popularized the use of quantifying the percentage of omega-3 fats as a percentage of fatty acids in cell membranes. What do you think about that for preventing sudden cardiac death? And do you recommend people take omega-3 fats?
Yeah, so I think the omega-3 index is important, but I think what gets misunderstood about it is that supplementing omega-3 isn't the best way to improve your omega-3 index. It turns out that lowering your intake of omega-6 is a better way to improve your omega-3 index. So, the data around omega-3 supplementation, fish oil supplementation, is really all over the place. Some studies show benefit, other studies show harm, and many studies are kind of neutral effect. So again, and this is another concept that I think we see repeating itself in medicine. We look at the level of a marker. And vitamin D is another good example. And you say, okay, low vitamin D definitely correlates with all sorts of diseases. But that doesn't mean that supplementing vitamin D is going to eliminate these sources. And I think if you can find ways to improve these markers through your diet and your lifestyle, that's always going to be better than the supplementation approach.
Well, so many people are scared of the sun. I mean, that's the problem. So
Right.
It's like, okay, take the pill or go in the sun. Sun equals wrinkles, skin cancer, so I'm going to take the pill. But we know that there's many other intangible benefits. I mean, it's very sunny outside. I just went in the sun for an hour and feel amazing. But again, that's a hard sell. But there's so much conflicting information from all sorts of specialists, dermatologists, and this. So what are your thoughts? Instead of supplementing with vitamin D, go exercise outdoors?
Yeah, no, definitely. And again, I think sun exposure is something that we've misunderstood, and again, ties into all of this. One of the reasons that the skin is susceptible to damage from the sun is when we have high concentrations of polyunsaturated fats in the cells of our skin and the subcutaneous, the fat layer underneath there. So again, many people have had the experience, and this hasn't been, I would say, scientifically validated, but many people have had the experience that when they eliminate polyunsaturated fatty acids from their diet, all of a sudden they don't sunburn anymore, and they're able to better tolerate being out in the sun for hours. And again, that raises their vitamin D level and has all sorts of beneficial effects. So I'm a big fan of getting out in the sun. I think it's certainly one of the pillars of good health. I consider myself fortunate to live down here in Florida and to be able to get out in the sun most of the year.
That's awesome. And so do you wear like a zinc sulfate, natural sunblock if you're going to be in the sun for extended periods of times, or are you not worried about that?
No, I've really stopped using, any sort of sunscreen lotions. I think I just have a very practical approach that if I feel like I'm getting to that point that,
it's hurting,
you go inside or you put a shirt on or, and you cover up. Again, I've had that same personal experience of going from being a very easy sunburner to now I can really be out for hours in the, midsummer, midday sun without sunburning.
Yeah, that is so. I've been hearing that from so many people, and myself have experienced that as well. I would love to see a case study or a clinical trial on this because it's incredibly fascinating.
Yeah.
One biomarker we haven't really talked about is triglycerides, and there was this whole notion of looking at non-fasted triglycerides because in the post-meal window you get this issue with hyperlipidemia and hypertriglyceridemia specifically. What do you think of triglycerides as a biomarker, and maybe even how would you correlate higher triglycerides with, in terms of how would you weight cardiovascular risk? We talked about LDL versus triglycerides. Where do you weight those two biomarkers?
Yeah, so I think triglycerides are a very important marker. In most studies, in most studies that look at both triglycerides and LDL in terms of their magnitude of risk, triglycerides comes out as a higher magnitude risk factor than LDL cholesterol. And there are confounders there because triglycerides is one of our markers of insulin resistance. Insulin resistance raises triglycerides. Yeah. Insulin resistance also is going to affect the quality of your LDL particles. Lowering triglycerides by improving your metabolic health, definitely beneficial. Now, it's interesting, the studies using drug therapy to lower triglycerides are not as clear. The main agent that we have from a drug standpoint to lower triglycerides is actually high-dose EPA, omega-3s, I would say the data on those pharma agents has been mixed. Kind of unimpressive, to be honest. I think when you lower your triglycerides by changing your diet, changing your lifestyle, improving your insulin resistance at the same time, definite benefits there, and highly encourage it. So I think triglycerides are a great marker. It's one of the main things I look at with my patients as well. And it's nice because it's easy. The patient that has come to you that, their practitioner will only order the sort of basic blood work, the lipid panel. And again, they've ordered it because they're looking at the LDL, and I'm looking at the triglycerides, more so than the LDL.
Yeah, I think it's been incredibly fascinating, and the fact that more healthcare practitioners are actually encouraging patients to not fast before looking at these lipid markers is interesting. I was playing around in 2017 doing the bulletproof coffee and things like that, and I found my triglycerides tended to increase pretty profoundly after. And so having bolus amounts of liquid fat was something that I changed my mind on as being health promoting. Now, if I had Parkinson's or was working with someone with Parkinson's that needed to be in a deep state of ketosis, that would be a little bit different. But I think that the utility of non-fasted triglycerides as an indicator of insulin resistance, which is driving everything we've been talking about, is pretty interesting.
Yeah, and as we get more and more capabilities to monitor things on a continuous basis, certainly the continuous glucose monitor has become ubiquitous, but you start to think about what other markers might be useful to measure on a continuous basis, and you think about things like triglycerides or maybe even free fatty acids, even better. Ketones, lactic acid levels. As the technology continues to evolve, I think we're going to be able to understand a lot more about these dynamic fluxes in our body and what the effects of all these various things are on them. And I am very optimistic about that because I think that then shows us the way. When we can measure continuous glucose, continuous ketones, continuous insulin levels, and we see the effects of these dietary changes, that's going to lead us to the true path to better health.
I wholeheartedly agree. I think Apple is making some progress there, and other companies, which are fantastic. I want to sort of close on hormones, and I think it's important because a lot of women are going through menopause, and one thing that you mentioned at the start is women are generally 10 years behind the men. As you can allude to shortly, a lot of that is the hormonal shifts that occur through menopause. Are you a big fan of women after menopause getting on bioidentical hormones and things to help to prevent future cardiovascular disease risk?
Yeah, so I would say that, it's interesting the thinking on this, and the shift. So, of course, there was a concern going back a number of years that things like hormone replacement may increase cardiovascular risk. And that was based on some studies that were probably flawed. There's also the confusing factors of, how are you replacing your hormones? Are you using bioidentical or are you using synthetic hormones? I think clearly bioidentical hormones are better. I think if you're having significant symptoms of, menopause, perimenopause, I'm a big fan of bioidentical hormones. And I think we have the data now to conclusively say it's not increasing your cardiovascular risk at all. And it very well may be decreasing your cardiovascular risk. Mm-hmm. So women shouldn't fear doing it. Yeah. And, I would tell them that it primarily should be used basically to manage the symptoms of menopause and perimenopause. I wouldn't do it primarily to lower my cardiovascular risk, but that might just be a good side effect of it ultimately.
Right. So if one is having symptoms, hot flashes, for example, low energy, low libido, vaginal dryness, all that, consider hormones. Now, what about for men? Because we know low testosterone is an independent risk factor for heart disease, right?
Yeah, and what's interesting about the low testosterone data is, again, how much of that low testosterone is actually due to metabolic disease. Because one of the things that I've now started to see consistently in my male patients is when we improve their metabolic health, their testosterone goes up. So it's another example of, let's not just treat the number, let's figure out why that number is low. And if we can get to that root cause, that's going to have better effects than just treating the number with testosterone replacement therapy. Right. Ultimately, again, I think similar to the conversation around women's hormones, if you're having symptoms of low testosterone, testosterone replacement can definitely be helpful. I prefer, before you go to that route, if you can figure out why your testosterone is low, if you have unrecognized metabolic disease, which many men do, let's fix that first. And then let's see, if your testosterone is still low and you're still having symptoms, then certainly I think TRT can be helpful. And again, TRT, similarly, there have been concerns that, can it increase cardiovascular disease? Mm-hmm. I think well done TRT is very safe. Poorly done TRT, I think, can get into those effects. So, for instance, if you're running very high testosterone levels, and that's going to increase your hematocrit, the concentration of red blood cells in your blood, that can get you into a situation where you're increasing your risk of blood clotting and cardiovascular disease. So you just want to avoid that situation. But if you're doing, TRT well and someone's monitoring you well and your levels are staying in the reasonable range, not a concern.
Right. I think that's a really important qualification because many people are at high risk or they're not addressing the root cause of why the TRT is low, and just hopping on TRT and having the thickened blood and everything like that could be problematic. So again, this theme is recurring from fish oils to using fish oil to lower triglycerides to just masking metabolic dysfunction with giving hormones. We got to address the root cause, and that is metabolic syndrome and insulin resistance and its associated sequelae, which is really important. So the reducing intake of processed foods, junk foods, bakery goods. Are there any studies, people that are going in for bypass, is there certain foods that are commonly, these people commonly eat? Is it sugar-sweetened beverages, sodas, smoking? Can we pinpoint it down, or is it just all the whole bucket of processed food that really is causing that?
Yeah, I think ultimately, the bucket of processed food, in the same way that, trying to villainize meat as, one aspect of it, I think trying to villainize, one particular part of the diet becomes difficult. Can I really say it's sugar versus, the vegetable and seed oils, for instance? So I think elimination of processed food, eating whole real food, that's really the sort of high-arching, high-level concept that I put forward to my patients. And, it's interesting, in my heart surgery patients, I'm now able to have that conversation with them. And the conversation is that the heart surgery isn't fixing the underlying problem. It's not addressing why you got here in the first place. It's oftentimes necessary, life-saving, can make the patient feel better, can literally save their life in the midst of a heart attack, but it's still not addressing the underlying root cause. And if we don't address the underlying root cause together with the heart surgery or putting the stent in, those patients still usually end up dying of heart disease, like I said earlier. So now I am better prepared to have that conversation with patients. And while my primary goal is to keep people off my operating table, even if you end up on my operating table, I want to keep you from coming back to the operating table. And there's still a powerful opportunity to do that.
That's huge. What percentage of these patients are morbidly obese or obese? I mean, is there a lot of fat on the inside, skinny on the outside, so-called TOFI phenotype in these people that you're operating on?
Yeah, we do see that. The perception, again, is, or the misperception is that only obese people end up needing heart surgery and develop heart disease. And that is certainly not true. I operate on plenty of people that appear lean. And again, the common finding is they usually have a lot of visceral fat. They're usually that kind of TOFI, thin on the outside, fat on the thin on the outside, fat on the inside, like you said. And when you look at their metabolic health markers, you see the metabolic disease there.
And do you actually see the ectopic lipid deposition in the heart when you're operating?
Yeah,
often?
so, epicardial fat, the fat that's on the outside of the heart, is another form of visceral fat. We talk about the visceral fat usually in the abdomen, but I see it on the heart as well. And I can do comparisons between patients that I'm operating on their heart for non-atherosclerotic reasons, people maybe with a valvular problem or a congenital heart problem, and comparing those hearts to the patients with atherosclerotic disease, you can visibly see the difference. I've posted this many times on social media, that we definitely get that visceral fat covering of the heart. And sometimes it becomes a challenge to me as a surgeon to even find the blood vessels under all that fat, that we're trying to do the bypass to. So,
wow.
Bad situation.
So do you suck it out? I mean, what do you do in that scenario?
No, we actually kind of cut through it, essentially, to get to the blood vessels that are underneath.
Wow. So it becomes embedded in the heart muscle on top, like a sheath?
It's on top, yeah. It's an outer covering, essentially.
That is
develops.
crazy.
Yeah.
So the body's just trying to get, it's just fat overload from probably conversion from sugar, excess energy, and is just putting it everywhere.
Exactly.
Is that what's going on?
Yeah.
That's pretty scary to think about. That's happening to the liver and the pancreas and the heart. I mean, wow. I mean, I think if people could see that on an MRI, what their food choices are doing, that would probably motivate them to stop, you would think.
Yeah, I think so. And I think imaging for visceral fat, again, is another powerful tool that we now have available to us. Going back to the coronary artery calcium scan, one of the things that's interesting is, the way that the scan is done, they'll get to the upper abdomen, and we can see the liver, and we can see fatty liver, and we can see visceral fat depositions. Besides just getting your coronary artery calcium score, I always encourage my patients, I want to see the actual pictures, and I think doctors should do this more. Look at the actual pictures, because it's not just about your calcium score. If you have a 0 calcium score, but I see a fatty liver and load of visceral fat, you're still in danger, and we need to address this.
So the CTCA is looking at that anyway, so you might as well get the data is what you're saying.
Exactly, and unfortunately, a lot of times the radiologists, the doctors reading the study, aren't looking at that because they're focused on the reason we got the test, which was the coronary artery calcium score. But more and more, I am seeing radiologists kind of wake up to this fact, and they mention fatty liver or increased visceral fat, and again, that can be another useful indicator of where you stand.
Totally. Yeah, if your body's getting the radiation, you might as well get the report,
Exactly.
Final question for you. What about carotid intimal media thickness, CIMT?
Yeah.
What's the value there? Is there any?
There's some, but I don't think it's as good a test. The advantage of the CIMT test is it's more easily repeatable. It can be done in the doctor's office. If it's done well, I think it's an okay marker. It doesn't always correlate with what's going on in the heart, but there is some correlation. It can be an early indicator, and like I said, it's even more easy to repeat that than getting another CAT scan. There's no radiation, but it's got to be done well. It's hard to get a truly consistent, repeatable CIMT assessment. So it can be a useful tool. I still prefer the coronary artery calcium score.
Maybe if we have robots in the future that can not have human error in there, we could have a reliable CIMT.
Yeah.
Fascinating stuff. Dr. Phil, I think we could talk all day about all these different topics, but you have a great book and a YouTube channel yourself. Where can folks find your book?
Yeah, so Stay Off My Operating Table is the book, widely available, all the usual places, and then iFix Hearts is where to find me. You can go to ifixhearts.com, social media, find me at ifixhearts. My team and I work with people in all sorts of ways. I have a private telemedicine practice that I work with people one-on-one. We have coaching, individual, group coaching programs. We have a ton of resources, courses, the book out there. So
awesome.
My overall message to people is figure out where you stand from a metabolic health standpoint, empower yourself to improve your metabolic health, and that's going to allow you to stay off my operating table ultimately.
That's key. I love that you have this resource because there's many people that are frustrated with their own doctor and they don't know where to go. And I think your platform is a great tool for them because they can actually get science-based advice and work with someone like yourself so that they're not banging their head against the wall fighting whether or not they should be on a statin or whatever else medication. So I just love that you're sharing this content, which is fantastic. So I appreciate you coming on the show. This is fantastic.
Thanks, Mike.
Thank you.
We finally got it done.
I know, we did. A lot of great info shared. Thank you.